Hello. So, hi everyone. Namaste. Today I'm going to be talking about clinical grade diabetic retinopathy AI that we built in our hospital for the people of Bangladesh. So, just like the problem in India, we have a lot of population that has less access to eye care, and there's a lot of it in the most remotest areas. So, what we thought is that we would use the power of AI to help with the diabetic screening in the rural communities. So we built a deep learning model AI, but we aligned it with the National Health Service of UK, the DESP grading. So why did we do that? Because the UK National Health Service has one of the biggest diabetic eye screening program across the whole country. It's amazing for faster triage, and it also takes like less photo for like detection. So we thought instead of ETDRS, we would use the NHS DESP grading. So now in my presentation, I'll just break it up into three small parts, right? First, I'll talk about the model architecture, then I'll talk about the workflow, and then finally, what challenges we faced when we implemented it in the tribal communities. So as for the model architecture, we used the Redfound Foundational Model, which is one of the topmost ophthalmic model built by Moorfields Eye Hospital. So we used it to fine-tune it with the Bangladesh eye dataset. So we had around 63,000 hospital data set that we used to train our AI. And then we definitely made sure to have the GradCam explainability because as I told you that if the AI just gives a diagnosis, it doesn't help. The doctor needs to know where the AI is coming from. So that's why we use the GradCam explainability. So this is a very cool data set images that we have. But what's even cooler is when we extracted all the features out, this was one of the biggest annotated data set that we did in our hospital. As you can see, all the most minute exudate, hemorrhage, the new vessels, all of those were extracted out. And this was done with the help of clinicians in the whole journey. And as I mentioned about the Redfound model, this is a model that was built in UK Moorfields with 1.6 million retinal fundus images. We used it to fine-tune it for our AI. And then we also used the lesion segmentation model where, as I showed you before, all the features were extracted and then they were used to help with the GradCam explainability so that the doctor knows where the AI is coming from. And then finally, we're very happy with our results. It showed high accuracy, and then also in the lesion detection, it was able to properly detect the exudate microaneurysms and hemorrhages. So it was a very good results on that end too. And now we come to the second bit, the workflow. So we did it very simple. Nowadays, for better accessibility, everything has to be on the smartphone. So what we did, we built a smartphone application. So you just log into the app, you create the patient entry, you take the image with a portable fundus camera, and then you upload the image. The AI detects the images and generates the results offline. And then the results can be transferred to the patient in their SMS, and it's also saved in the server. Now for the second one, what's the workflow in our rural center? So a patient walks into our rural center, we take the patient data, and then we take the image with the portable fundus, and then that image is then given to the AI. The AI generates a result. But here's the catch, we wanted clinician in every aspect of it. So if there's any single doubt of the AI analysis, the technician can escalate it real time to the doctor in the tertiary hospital who also has access through the smartphone. So they can see the AI image and they can either override or approve the AI. So finally, the patient gets a final diagnosis, and then we used it for the follow-up treatment so that the patient can get treated into our tertiary hospital. And as I mentioned, so this is our target population, the Chittagong Hill Tracts. As you can see, it is far away from the Midland and right away in the deep corners of the hills, and very poor and lack of access to eye care. So the initial challenges that we faced was definitely the language and communication barrier. As you would see in all the presentations here, even Google or even ChatGPT, they only know mainland languages or English. But we have so much tribal dialects that none of the AIs, like the generative language models right now, can't recognize. So that was a huge barrier. The second one is definitely when you're in the remote hill tract areas, there's definitely going to be poor cellular coverage. And then finally, technological interaction barrier. We're saying we're building the AI, we're putting it in the smartphone for the accessible of the patients. But if the patients doesn't know how to use the smartphone, which is very much the case with our baseline study in the Bangladesh rural areas, so then all of this is for naught. All the thousands of dollars that we spent for the AI just comes to naught. And finally, the environmental imaging barrier. And this is very tricky because sometimes when we go to the most remote corners of the hills, we don't even have a health complex. So we're just doing like an open field screening, and we know all of our AI is dependent on the imaging quality that we receive. So because of sunlight or any other thing, or like lack of illumination, you get bad images, so you get bad results sometimes. So as you can see, that's me with like a really sunlight heavy area. And then in the tribal hill areas at the start, we saw that the AI illumination was very bad. And then, but in the hospital, it was the same device and it was much clearer. So, but we did find some solutions. So first thing that we're very proud of is, the first thing that we did was, if we're going to the indigenous areas, we need them into the play. So we had focus groups with the tribal communities, and we tried to build everything around their tribal language, like the pamphlets or any health information or anything. We try to incorporate their input into our AI. And secondly, definitely we would have the offline first AI architecture because there is lack of cellular coverage. And finally, the portable imaging countermeasures. I mean, for now, what we did, because this is a very new concept, so we did it in the hut of, like in one of the houses of the people. They're very gracious, as you can see in this image. But moving forward, we plan to implement portable tents, and we want stricter portable imaging control measures. So that's it. So that's how we build the Bangladesh's first retinal AI system. And this is a short video. Please enjoy.
No days off, no excuses, pain talk, I speak fluent. Day rest, I keep moving, same goal, new bruises. No days off, no sleep, mind sharp, routine beat. You wish I repeat, every rep build belief. Alarm ring, I'm already up, same grind when it's hard as fuck. No crowd, no camera, just I and trust. I don't need cheers, I need results. I don't count likes, I count reps and faults. When
That's it. So, okay, I think it went away. But that's pretty much it. Thank you so much, everyone, for giving me the opportunity to talk. And thank you so much to Dr. Devashish, sir. So that's my dad, and that's my mom in the front row, and my grandma too. So it's like a nice presentation for me. So thank you so much, everyone.
Hello.
Thank you. It's a very nice presentation.
So I have
Pradipta?
a doubt.
Yeah,
Can
please.
I ask a question? Yes. So, hi.
Yeah.
Very good presentation,
Thank
sir.
you.
So we have been practicing something like this at our setup in Bhopal as well. We have deployed our AI as well. I had a question. Is this
Yes.
Medriatic or non-Medriatic?
Non-majority.
Non-Medriatic.
Yeah.
Okay. And sir, in one of your slides, you had mentioned that the technician flags the if he sees anything suspicious, he flags, and then that image is transferred remotely to the doctor.
Yeah.
Is the technician a grader as well?
Yes. So this project has been done in collaboration with input from the Moorfields Eye Hospital. So we have a vitreoretinal surgeon and their grading system teaching our technicians of the imaging standards. So this is another safety net that we put. So the AI has been already trained to the max. On top of that, if the technician sees something that is like off the AI results, he or she can escalate it to the reviewer, and they can either approve or override the AI.
Okay. And if it's an offline model, then how are you going to send it remotely to the doctor and the real time if there is poor internet connectivity?
That is something that we're definitely working on. So on some of the areas that we have piloted, there were some Wi-Fi, but on the other ones that didn't, we gave out with the AI diagnosis. But that's definitely what we're looking into, of sending the data from the plane to the tertiary hospital. But another feature that we are trying to look into is with the doctor also, we also have like the camp also has some doctors around there. So they give sometimes input, but definitely the offline first architecture, this is a plan in progress.
Okay.
Yeah.
Okay. Thank you. And what is your referral outcome, like follow-up? How many patients that you refer actually turn up to your base?
We made sure that, because here's the thing, right? When you implement it into the rural areas, you screen, but most of the time the patients can't reach all the way to the tertiary place. So that is a very big challenge, but on we have a privilege So our hospital is part of the Lions Eye Hospital, like a Lions Club International. So we have member organizations in each of these hill tract areas. They take the responsibility of any patient that has been diagnosed, is provided free transportation to our tertiary hospital and then transported back to their villages. So that's how we maintain that, like, no poor people gets like unscreened, or like we just don't stop at screening. We stop at the full circle of treatment and then also the final health of the patient.
Okay. So do you have any percentage for that? How many percentage of patients actually turned up at your base?
Yes. So, I mean, if you are implementing it on the real field, the number of PDR cases, I mean, it's going to be around like 10 to 20%, right? So all of those people that has been diagnosed with treatment, because ours is a referral system, so normal patients are asked to come like after like a year or so, right? But anything that does require treatment, we make sure to follow up with them, and like a high percentage of them has reached the hospital.
Thank you. I do have more questions, but due to want of time, I'll ask you afterwards.
Of course. We
Thank
can
you so
connect
much.
later. Thank you
Food
so
for
much.
thought for you in Bhopal.
Thank you so much. Thank you.
Thank you. Thank you.